Hello everyone. In this session, I'm going to discuss about neonatal seizures. So as an introduction, you know that children are at highest risk for seizures during the first month of life, that is during the neonatal period, that is up to 28 days of life. Seizures in newborns are usually symptomatic of an underlying acute injury, such as hypoxic ischemic encephalopathy or stroke. So seizures are reflective of an acute symptomatic cause. That is what we call an acute symptomatic seizure, right? So most neonatal seizures are subclinical. That is another fact which you have to bear in mind, because most seizures which we see clinically means that we are missing lots of seizures which are subclinical. They can be picked up only on the EEG. So it is said that up to 50% of seizures in the neonatal period due to acute symptomatic causes, including hypoxic ischemic encephalopathy, which is the most common cause, are said to be subclinical, hence an EEG is required for diagnosis. So with this introduction, let's move into the pathophysiology of neonatal seizures. So as I told already, the first 28 days present the highest lifetime risk for seizures. Acute symptomatic seizures caused by birth trauma or hemorrhages leading to hemorrhagic stroke, or an infarct leading to ischemic stroke, or hypoxic ischemic injury or encephalopathy, perinatal infections, and metabolic disturbances, all these account for more than 80% of seizures. So the seizures are a symptom of an acute neonatal medical cause. So it is not a reflection of epilepsy. It is not a reflection of the inherent brain's tendency to cause seizures. It is due to external disturbances that the newborn throws seizures. So the immature brain is highly susceptible to acute symptomatic seizures because of age-dependent mechanisms that lead to excess excitation, reduced inhibition. So you know that the neonate's brain, because of its inherent need to develop new axons and dendrites and neurons, has a state of generalized, excess excitation and reduced inhibition. That is why the newborn period is at a high risk for development of seizures. So are these acute symptomatic seizures non-deleterious? No, they are deleterious to the developing brain because they impact neurodevelopment in the future. So that is because excessive seizure activity in the brain leads to reduced density of dendritic spines in the hippocampal pyramidal neurons. It leads to decreased neurogenesis, and it leads to delayed neuronal loss, not neuronal loss during the acute period, but due to causes delayed neuronal loss, and it causes long-time changes in hippocampal plasticity. So that is why newborn seizures have to be watched for and picked up. Even if they are subclinical, they can damage the brain and lead to adverse neurodevelopmental outcomes in the future. So in rodent models, neonatal seizures increase the susceptibility to unprovoked recurrent seizure, that is epilepsy, later in the animal's life. So this has not been replicated in the humans as strongly as in the rodent. But yes, seizures during the neonatal period, the burden of seizures, as we'll see later on in the lecture, the burden of seizures during the newborn period increases the chances that the child develops epilepsy as well as adverse neurodevelopmental outcomes as the child grows. So what are the mechanisms of neonatal seizures? So the primary mechanisms, as I told you, the inhibitory mechanisms are downplayed during the newborn period, and the excitatory mechanisms are in the upper hand. That is, GABA mediated inhibition is less pronounced than glutaminergic mediated excitation. So this favors excitability during the newborn period. Excitability is enhanced during the neonatal period. Why? Because this is due to physiological need for the newborn brain to have an excitatory excess during this period, because synaptogenesis and a lot of neuronal plasticity is going on. The brain is very actively growing rapidly during the first year. You know that the brain grows in its most rapid speed during the first year of life. That is why we have a very rapid, around 10 centimeter increase in the head circumference during the first 1 year of life. So this is why the brain needs to be in a constant state of excitation, and that is a downside because this provokes the newborn to have seizures for any acute illness. So one of the important causes of why the newborn has a high excitability is because of the GABA shift. So GABA has it is an inhibitory neurotransmitter otherwise, but in the newborn, GABA stimulation can be excitatory, right? So this is because you can see very well in the figure that the red receptor is the GABA channel where GABA acts. It is a GABAergic channel. So it is a chemical ligand gated ion channel which opens for chloride currents. So when you have the chloride concentration inside the cell is going to be higher, there is an efflux of chloride from inside to outside. So anything which is going from inside to outside is going to make the outside membrane electronegative, and hence that is going to disturb the resting state. So this is going to lead to an electrical discharge as indicated in this picture by this electrical potential, right? So in the newborn period, so what controls this chloride is the question. So in the newborn period, it is that there is excess chloride influx into the cell because of an importer called the NKCC1 importer. And what has an opposite effect is a KCC2 exporter. So in the newborn period, the number of KCC2 exporters are going to be less and NKCC1 are going to be greater. Hence, the tendency is for increased chloride concentrations inside the cell. So whenever GABA acts on this ligand-gated ion channel, because chloride has a higher concentration inside, it is going to efflux, leading to change in the resting membrane potential, and thus that is going to cause an electrical impulse. So this reverses during the later infantile period, that gradually number of NKCC1 importers are going to come down in the mature neuron, and KCC2 is going to be the primary chloride channel. So that is going to lead to an efflux of chloride current from inside to outside, leading to less chloride concentrations inside the cell. So whenever GABA acts on this ligand-gated channel, there is going to be a net influx of chloride. You know that when the outside potential is positive and inside potential is negative, there is going to be maintenance of the resting membrane potential, which is not going to lead to any excitatory action potential. So this is why the newborns have a paradoxical response to the action of GABA on the cell. So another problem in the newborn is that the NMDA receptor subunits in the neonate are made up of the NR2B subunit. So there are two subunits, NR1 and NR2. NR1 is going to be the same across all age groups, but the NR2 is going to change because NR2 has different subunits, A, B, C, and D. Sometimes there may be a third subunit called the NR3, but we are not worried about that. So adults generally have, or bigger children outside the newborn period generally have the NR2A subunit. So when the newborns who naturally have the NR2B subunit, if they are going to have that, as is the case, it is going to lead to greater excitability because presence of this NR2B subunit changes the electrical property of the cell, leading to prolonged current delay and excitatory postsynaptic potential. So this is going to make the NMDA receptor more excitatory. You know that the NMDA receptor is usually excitatory. This is going to be more pronounced so in the newborn period. And as I had explained previously, GABA is not going to be inhibitory, rather it is going to be paradoxically excitatory. So these are two reasons why the newborn period has a higher chance of developing seizures, right? So the GABAergic medications which we generally use, such as benzodiazepines and barbiturates, which are the mainstay of initial treatment of seizures or status epilepticus, could in theory cause a paradoxical excitatory response. This is one of the reasons why in the newborn period we don't prefer prolonged anti-epileptic medications. For example, if a child has received phenobarbital for control of seizures in the acute period, we don't give it for a longer time because this is going to lead to excitation-mediated neuronal damage later on, which is going to affect the neurodevelopment of the infant adversely. So nonetheless, phenobarbital, as you would see in the later part of this presentation, has remained and still remains and will also remain as the first-line agent in the future, because 50% of more of patients who receive phenobarbital have a good response to this medication for controlling seizures, right? So you should know that GABA agents are usually inhibitory, but in the newborn period, some proportion of GABA receptors, because of this adverse chloride current theory which I had explained, are not inhibitory enough or maybe excitatory. So this is theoretical, and this explains some of the things which we observe in the newborn period, such as the things which I explained, that one small proportion, a chunk of newborns who do not respond to phenobarbital as the first anti-epileptic agent may be having this as the mechanism behind their unresponsiveness. And the second one, as I told you, certain newborns may have bad neurodevelopmental outcomes if they are given phenobarbital for a long time. So that is why we restrict them to the first month or even lesser than that. So coming to the epidemiology of neonatal seizures. So the incidence of seizures in the newborn range from 1 to 3.5 per 1,000 live births. So this is a sizable incidence. It means that around 2 children in 1,000 live births can experience a seizure. This is a big number. True incidence, but it is difficult to determine because studies have been based on clinically observed or reported seizure-like activity. As I already told you, up to 50% of neonatal seizures can be electrical only. That is, they may be detected only with the electroencephalogram. Without that, you will be studying only, you will be assessing the incidence of only 50% of what is truly happening, right? So it is said that males and preterms, for less clearly well-known reasons, are at a higher risk of developing seizures. And there is a study where investigators observed a parabolic relationship between seizure incidence and gestational age, with children between 30 to 36 weeks gestation at lowest risk, right? And then the risk increases beyond this group, and later on it decreases after the newborn period, right? So this observation probably may be related to two most common causes of seizures: intraventricular hemorrhage and hypoxic ischemic injury. These two are more common in the younger and older age groups, respectively, because the children less than 30 weeks of gestational age have a higher risk of intraventricular hemorrhage, and generally children more than 36 weeks of gestational age are the ones which we see who have hypoxic ischemic encephalopathy, that is birth asphyxia in the newborn period. So this may explain this parabolic curve of seizure incidence. Seizures in the newborn usually occur in the first week of life. Up to 85% seizures occur in the first week of life, particularly in the first 2 days. First 2 to 3 days present the highest risk of newborn seizures. Most neonatal seizures, thankfully, are brief. A study estimated that 85% of neonatal seizures lasted less than 5 minutes, with 60% lasting less than 90 seconds. But the problem is that newborns have a high seizure burden. They may have these brief seizures, but they tend to have it repetitively multiple times per day. So what are the risk factors? So low birth weight, gestational age, all these I've explained previously. And male sex is again another risk factor. But maternal diabetes, maternal fever or infection, perinatal or postnatal infection, major comorbidities or surgical interventions in the infant, evidence of fetal distress in the perinatal period, and post-term delivery, something beyond 41 weeks of gestation. All these are known to be risk factors for neonatal seizures. See, as in any neurological disorder, we do not attribute a single neurological symptom to single cause. We attribute this particular symptom, that is neonatal seizures, to multiple causes. So these multiple causes are represented by risk factors. So for cerebral palsy, we do not talk about a single cause. We talk about risk factors such as prematurity, intraventricular hemorrhage, neonatal meningitis, hypoglycemia. All these are risk factors for cerebral palsy. Similarly, for neonatal seizures, we have a host of risk factors which may act in combination and lead to an increased risk. So the effect size of each of the single risk factors may be small, but together they add up and increase the risk or threshold for neonatal seizures. So those which are not established, there are certain risk factors. They include advanced maternal age, maternal nulliparity, and male gender, which I had already told you. But these have not been proven to have true risk factors. So what are the etiologies? What are the causes which we encounter in practice for neonatal seizures? As you can see in this diagram, hypoxic ischemic encephalopathy, HIE as we call it, represents a major chunk of the causes of neonatal seizures. Apart from that, vascular causes and infectious causes are equally important. Vascular causes means a stroke or a thrombosis or a bleed, right? Arterial stroke, thrombosis, or a bleed. Infection means acute infection of the brain like meningitis, encephalitis, or a systemic infection like sepsis, right? Other than that, metabolic, genetic causes and malformations of the brain, as well as unknown causes, contribute to the minority. So the causes of seizures, as I told you, in newborns are numerous and diverse. A single newborn, as I told you, can have more than one cause. So that is why we use the term risk factors for seizures. So determination of the seizure etiology, the number of risk factors of the child leading to seizures, is important because it has a say in treatment and prognosis. So though there may be one important risk factor for seizure, that we call it as the etiology, there may be other risk factors which contribute. For example, a child may have hypoglycemia as the most important and antecedent cause for seizures, but the child being preterm, having sepsis, having had intraventricular hemorrhage, all these may be additional risk factors which increase the risk or lower the threshold for seizures. So the etiologies can be divided into three broad categories. One is the acute symptomatic seizures, which we were talking about till date, right? Which is obviously the most common, accounting to more than 3/4 of the causes. Apart from that, you can have brain malformations, cortical malformations, which are called developmental anomalies of the brain, or seizures can be due to genetic or neonatal epilepsy syndrome. So this constitutes the minority, the smallest of the three groups, but you will have to remember them because some of them are very eminently treatable, as we'll see later on. So coming to hypoxic ischemic encephalopathy. So in the next few slides, I'll be discussing all the causes one by one briefly. So it accounts for around 50% of neonatal seizures. Seizure onset is within the first 24 hours of life. Usually, we do not get seizures due to hypoxic ischemic encephalopathy after the first 1 or 2 days. If you get that, then probably you're dealing with something else, or there is some other factor contributing for seizures during that period. For example, sepsis, meningitis, or hypoglycemia, hypocalcemia, anything like that, right? So it is important that in the era of therapeutic hypothermia for infants with HIE, it is mandatory that children undergoing therapeutic hypothermia also undergo prolonged continuous video EEG throughout cooling and rewarming, because these children can have something called electroclinical dissociation. So when you cool the brain, what happens is that many of the seizure discharges are not propagated and do not manifest as convulsive activity. When they're not going to manifest as convulsive activity, the clinician may not notice it. So most of the seizures, as I already told you, even in the uncooled newborn, there is a high chance of it getting missed. When the newborn is going to be cooled, this electrical and clinical dissociation is going to happen. So most discharges are going to be electrical. So a continuous EEG is mandatory. If a continuous EEG is not available in resource limited settings, then you should go for at least something called amplitude integrated EEG, which I'll show you later on, which is part of the continuous fetal monitoring. So it is something which you can attach to the child's head with the minimum amount of electrodes, and it is one of the monitoring parameters along with the child's blood pressure, heart rate, and saturation. You can keep monitoring this, and finally, at the end of the day, you can assess for the presence of subclinical seizures. Or at least, if that is also not possible, daily serial routine EEGs for the first 4 days of life for a duration of up to 60 minutes at least is suggested, right? So even though cooling may decrease seizure burden, so though cooling is the main purpose of using therapeutic hypothermia is to prevent adverse neurodevelopmental outcomes, but therapeutic hypothermia is also useful as an anti-seizure therapy. So though it may decrease seizure burden, around half of treated newborns may still have seizures during therapeutic hypothermia. And because of this peculiar phenomenon of electroclinical dissociation, it is mandatory to monitor these infants with an EEG during the time they are being cooled and rewarmed. Coming to the next common etiology, vascular etiologies for stroke. So arterial ischemic strokes is what I'm going to discuss first. So you know that arterial and venous infarctions and intracranial hemorrhages, all three are grouped under vascular causes. And these, as a group, vascular causes the second most common cause of neonatal seizures. Up to 15-20% of seizures are caused due to these vascular causes. So among them, arterial ischemic perinatal ischemic strokes occur in 1 in 2,300 to 5,000 live births, and they're typically the result of embolism from the placenta or the umbilical cord. Very rarely they can come from thrombi in the carotid artery or the heart, but usually the placenta or the umbilical cord, which is the culprit. So seizures are the most frequent presenting symptom of acute ischemic encephalopathy, acute ischemic stroke. And you know that a focal seizure in a newborn is due to an arterial ischemic stroke unless proven otherwise. They do not manifest with unilateral weakness or paralysis in the newborn period, right? So it is peculiarly noted that around 2/3 involve the left middle cerebral artery territory. That is probably because of the origin of the left carotid artery from the aorta, which allows a more direct vascular route for the brain, for cardiac emboli to reach the brain, because you know that right side you have something called the brachiocephalic artery, which then gives rise to the internal carotid artery. So the internal carotid artery on the left side, in contradistinction, arises directly from the aorta. So thrombi which have lodged inside the vascular system can easily reach the brain straight. So that is why left is more involved than right. So for strokes, you have a certain group of risk factors, maternal and neonatal. So oligohydramnios, clinical or histological chorioamnionitis in the mother, premature rupture of membranes, preeclampsia, diabetes and smoking are all maternal risk factors for strokes. Similarly, neonatal risk factors include congenital cardiac anomalies, systemic infections, coagulation disorders in the neonate, placental abnormalities, and again, peculiarly male gender, right? So these are the risk factors which you'll have to remember. When you discuss vascular strokes, you should not ignore cerebral synovenous thrombosis and intracerebral hemorrhage. You know that the highest risk of a child or a human to develop CSVT is in the newborn period. So usually it involves the superior sagittal sinus and or the transverse sinus in neonates, that is term neonates. Whereas in preterm neonates, it can lead to medullary vein thrombosis. So the appearance of these thrombi are a little different on the MRI scan. So this is not to discuss right now. So again, CSVT has a group of risk factors. So in newborns, in most of the neurological disorders, we do not discuss about a single cause. We implicate a series of risk factors, right? So similarly, CSVT can have maternal, fetal, neonatal risk factors, and thankfully they are the same as those outlined earlier for arterial strokes. So many children have a combination of predisposing risk factors, and you know that infection and dehydration are very important risk factors. In addition to congenital conditions, inherited thrombophilias, as we call them, these are very important. These may present in the newborn period with stroke and CSVT as the primary manifestations, hence it is necessary to screen for them, right? So coming to hemorrhages, you know that CSVT itself is an important cause of hemorrhages because venous strokes also have hemorrhage as their components. These are called wet infarcts. So apart from CSVT, the important cause of hemorrhages in the newborn are intracerebral hemorrhages due to trauma, coagulopathy, or vascular malformations, right? So other than that, in children who have been subjected to a traumatic labor due to vacuum extraction or assisted delivery techniques, they can sustain subarachnoid and subdural hemorrhages. And they're generally very mild and not significant. They usually are asymptomatic. What is more important is that in the preterm, intraventricular hemorrhage, that is particularly less than 30 weeks of gestation, these are very important. These can be symptomatic in the form of seizures, encephalopathy, apnea, enlarging head size, hydrocephalus, right? And when they occur in a term infant, you should always suspect cerebral synovenous thrombosis. It's very unusual for intraventricular hemorrhage to occur in a term infant, right? So as I told you, IVH is important in preterm infants, but seizures are not associated with the milder grades of IVH, only those which reach grade 3 or grade 4. Grade 4 is otherwise called periventricular hemorrhagic infarct. And these are the ones which generally cause seizures, and they typically occur in the first 3 days of life, generally not beyond the first week. Coming to infections, the third important cause of seizures in newborns are infections. Infection does not mean just meningitis or meningoencephalitis. They can also include systemic sepsis as well as congenital infections, that is in utero or post-natal infections, right? So the viral etiologies which we should remember in this group are herpes simplex viruses, cytomegaloviruses, paracoviruses, lymphocytic choriomeningitis virus, and disseminated enterovirus and parvovirus. So in these, herpes simplex virus and paracovirus are very characteristic MRE pictures, which probably in the later lectures I will be discussing about. But these are very two important causes, which obviously HSV is treatable, and paracovirus produces a very mild white matter kind of inflammation, encephalitis, which again can be detected only on an MRI. It is very unusual to detect paracovirus in the CSF, or even the CSF shows no cellular response or elevated protein. But this has a very characteristic MRI picture, which is diagnostic, and these generally recover without any treatment. Bacterial sources include group B streptococci. These are, as you know, classified into early and late GBS infections. All gram negatives are important. E. coli is the most important of them. And you should also remember neonatal toxoplasmosis, that is as a result of in utero infection. So they are diagnosed with a lumbar puncture, that is mandatory. And children who are very unstable to undergo a lumbar puncture should be treated empirically for a CNS infection, because time is brain is what we generally consider in treatment of infective causes of neonatal seizures, right? And as I told you, certain neonatal infections can be identified only on the MRI scan, such as paracovirus. Some neonatal infections, such as herpes simplex viruses, have a very characteristic MRI picture, which can aid in the diagnosis, but you have molecular diagnostic techniques, including CSF PCR, to diagnose herpes simplex. And in bacterial infections, you do not need imaging to diagnose, because the CSF generally will give you results. But to monitor for complications, an MRI is necessary for subdural effusions, for thrombosis secondary to the infection, for brain abscesses, for ventriculitis, for all these, and also hydrocephalus, which may develop later on, and imaging is necessary. Coming to the next important group of causes which you should remember, metabolic causes. So among these, glucose, sodium, and calcium should come into your mind whenever you think of metabolic causes of seizures in any age group, more importantly in the newborn period. So hypoglycemia is a very important and a preventable cause, which leads to devastating outcomes both in the acute phase as well as in the longer neurodevelopmental period of the child. That is quite common. It has varying definitions. We know something like an operational definition in the newborn period for hypoglycemia. So roughly less than 45 milligrams per deciliter in term infants and less than 30 milligrams per deciliter in preterm infants constitute hypoglycemia. So risk factors for the development of hypoglycemia include maternal diabetes, small for gestational age infants, in conjunction with illness including sepsis, feeding issues in the newborn, and hyperinsulinism and pancreatic insulinoma, which are less common among these causes. Anti-seizure administration is necessary only if these seizures persist despite glucose boluses. So for the treatment of metabolic causes of seizures, correcting the metabolic abnormality forms the mainstay of treatment. If they are not getting controlled, just after controlling these metabolic parameters to normalcy, you may administer anti-seizure medications, right? So you should know that severe hypoglycemia can cause irreversible brain parenchymal injury, and it is localized to the posterior brain quadrants at the parieto-occipital lobes, which leads to very adverse outcomes, both in vision as well as behavior, development, and also leads to very intractable and bad post-neonatal epilepsy, right? Coming to hypocalcemia, again, it is an important cause of neonatal seizures. Around 1% of neonatal seizures are caused by this. It is defined based on free ionized calcium levels rather than total calcium. Total calcium may be low normal and can be very dubious. So you always look for a free serum calcium or an ionized calcium. So you can group causes of hypocalcemia into two groups. One is early onset and another is late onset. So anything within the first week of life is early onset. Generally, that occurs within the first 3 days of life, and it is associated with low birth weight infants, maternal diabetes, HIE, and endocrinopathies. Again, you have a group of causes, one or more than one may be responsible for hypocalcemia. Whereas late onset causes, generally we look for them after 1 week of life, is associated with maternal hyperthyroidism or maternal vitamin D deficiency, or maybe a manifestation of a syndrome like Dye-George syndrome, or may be caused by high phosphorus containing formulas or use of cow's milk. Among term infants, you should always consider hypernatremia as an important cause, because term infants, when they're discharged home and they're subjected to faulty feeding, can result in sodium imbalances leading to hypernatremia. This is generally caused because of abnormal maternal nutrition as well as a combination of incorrect mixing of the formula or severe dehydration. Both of these can exist together, or it can be a complication of intracranial injury, right? So severe dehydration with hypernatremia and seizures may also be associated with cerebral sinovenous thrombosis, because all these are interlinked, right? So severe dehydration may lead to hypernatremia, and both these become risk factors for leading to increase blood viscosity, and they can produce sinovenous thrombosis, and this can lead to seizures independently as well as acting in unison, right? So CSVT leads to encephalopathy that may lead to decreased feeding and then dehydration and hypernatremia. This is a vicious cycle. That is why we think of risk factors rather than a single important cause for seizures in an infant, particularly in metabolic problems. Coming to the other group of metabolic problems, the congenital ones or the inherited ones, the inherited or the inborn errors of metabolism. So seizures can be associated with a group of disorders, including urea cycle defects, which is evidenced by hyperammonemia in the blood, organic acidurias and amino acidopathies. Generally, we have metabolic acidosis, right? So apart from these common groups, urea cycle defects, organic acidurias, and amino acidopathies, we have a group of metabolic epilepsies or metabolic epileptic encephalopathies. These are uncommon, but they have to be remembered because they are treatable. So they can be classified into three groups, which I'm going to briefly discuss: disorders of neurotransmitter metabolism, disorders of energy metabolism, and biosynthetic defects causing brain malformation, dysfunction, and degeneration, right? So among these neurotransmitter disorders, you should remember vitamin responsive epilepsies. So they include pyridoxine-dependent epilepsy, pyridoxal 5-phosphate responsive encephalopathy or epilepsy, and folinic acid responsive seizures, or FARS as we call them, right? So apart from these, there are other neurotransmitter disorders, including aromatic amino acid decarboxylase deficiency and other group of disorders affecting GABA transmission. These are things which you may not remember, but pyridoxine-dependent epilepsy and the related group of disorders are very important because they are very easily treatable. So PDE is caused by a rare autosomal recessive mutation. It is in the ALDH7A1 gene. This gene encodes for a protein product called antiquitin. So these seizures rapidly respond to intravenous pyridoxine. So pyridoxine administration trial is warranted for newborns with unexplained treatment-resistant seizures. Pyridoxine 5-phosphate deficiency again is related to PDE, but these patients do not respond to pyridoxine and they have very bad seizures and encephalopathy. So when children do not respond to pyridoxine, it is warranted that as a second step, you should always give a trial of pyridoxal 5-phosphate. Coming to the second group of disorders, energy metabolism disorders. Again, there are multiple, but I want you to remember a few. One is the glucose transporter deficiency, right? And the other causes include creatine disorders, which among these causes, probably this one, that is glucose transporter deficiency, disorder of creatine synthesis, and biotinidase deficiency are three disorders which can be treatable. So creatine supplementation is useful for creatine disorders, metabolism disorders. Glucose transporter deficiency, also called GLUT1 deficiency syndrome, is treated with ketogenic diet. And biotinidase deficiency, if you give high dose biotin, they're going to respond very eminently. Apart from this, we have a lot of causes: sulfate oxidase deficiency, Menkes disease, mitochondrial respiratory chain disorders, so on and so forth, but we are not going to discuss them. So biotinidase deficiency, as I told you, are very important. They're present with refractory seizures. Eczematous skin lesions and alopecia are important diagnostic features, but they may not present in the newborn period. So you should always supplement biotin when you do not have any other cause to explain the seizure. And then probably as the child grows, you may find the other features. So they can have a very variable age of presentation. The form of biotinidase deficiency, which presents the newborn period, is usually holocarboxylase synthetase deficiency or multiple carboxylase deficiency, as it is called. So they generally present with these features which I've mentioned already, along with a metabolic acidosis, increased lactate and ammonia. So they are also treated with biotin, but it is a severe form of biotinidase deficiency which is present in the newborn period. As I told you, glucose transport problems include GLUT1 deficiency. It is diagnosed by the presence of hypoglycorrhea in the CSF, and also associated with low normal or low CSF lactate. Generally in infection, CSF lactate is elevated, whereas in this condition, because glucose is not going to go cross the blood-brain barrier and go into the brain cells, it is going to lead to hypoglycemia as a result of a decreased lactate production. Right. So treatment is the ketogenic diet. Generally, they do not present in the newborn period. They present after the first 1 to 1.5 months, but they may present in the newborn period. It's important to check for CSF lactate. Another disorder which I have mentioned here because of its remarkable similarity to hypoxic ischemic encephalopathy in its clinical as well as MRI presentation is molybdenum cofactor deficiency and isolated sulfate oxidase deficiency. So these are partially treatable with pyridoxine supplementation and anti-epileptic medications, but these children will have a very bad refractory epilepsy course and a very bad neurodevelopment. So they generally have cystic white matter changes on MRI. These can be mistaken for HIE, but this is a metabolic disorder, right? So the third group of disorders which I had mentioned are defects leading to brain malformation. So they include peroxisomal disorders, congenital disorders of glycosylation, cholesterol synthesis disorders or lysosomal disorders. These are very vaguely termed large molecule disorders, but these are disorders which can cause multiple multisystemic manifestations as well as they can lead to brain malformations as well. You should remember Zellweger syndrome, which is the most important of the peroxisomal biogenesis disorders. They present with severe encephalopathy, refractory neonatal seizures, and subtle dysmorphic features. The diagnosis is made by the measurement of very long chain fatty acids and phytanic acids in the blood, right? So coming to the next group of disorders causing neonatal seizures, those are brain malformations. So these are, again, relatively common causes of neonatal seizures, but they are not very common. And they generally do not present in the first at least 2 weeks. They generally present at the end of 1 month or even more than 1 month. So they require MRI for diagnosis. Some examples of these disorders are hemimegalencephaly, lissencephaly, heterotropias, schizencephaly, polymicrogyrias, and focal cortical dysplasia. Generally, they present after the newborn period, but they are included because on occasion they can present in the newborn period. Right? Some newborns can have comorbid hypoxic ischemic encephalopathy because of the extensive brain malformation. They may not tolerate labor and delivery. Right? So neonatal seizures in the context of developmental brain anomalies are generally associated with very bad seizures and chronic epilepsy, poor neurodevelopmental outcome. But these, as I told you, thankfully do not present in the newborn period. But even they present as seizures in the newborn period, they are going to have a very bad course. There are certain neurocutaneous disorders, particularly tuberous sclerosis, which can present with seizures in the newborn period. Again, this is going to be unusual. And yes, you should have a clinical eye of suspicion for them because you do not have all the cutaneous manifestations. Neurocutaneous disorders require cutaneous manifestations for diagnosis, but they may not be present. And the MRI may not really clearly show that cortical tumors in this age. So you should always consider them. And later on, as the child evolves and the MRI appearances evolves, then you may be able to make a confident diagnosis. Coming to the last group of causes of neonatal seizures are the epilepsy syndromes. So these are among the huge list of causes. They come at the bottom because they are not very common, but you should remember because some are, very eminently treatable and some are untreatable, and it is important to test for them and talk to the family about the poor prognosis, right? So they can be benign or they can be very bad in course or severe. So the severe ones are called early onset epileptic encephalopathies. Epileptic encephalopathy means a child who is going to have multiple recurrent seizures, and the seizures are going to cause more and more brain damage in the form of poor neurodevelopmental outcomes. So that is what we call epileptic encephalopathy. These are commonly monogenic because they are due to one single gene mutation, right? So one example of a very benign condition which is easily treatable is the fifth day fits or the benign familial neonatal epilepsy. So when you have a family history, you call it familial, BFNE. When you do not have a family history, you call it BINS or benign idiopathic neonatal seizures. So also called fifth day fits. They are due to potassium channel mutations, KCNQ2 or KCNQ3 voltage gated potassium channels are mutated, which has a problem, which leads to a problem in repolarization of cell membranes, right? So you know that when repolarization is impaired, this leads to neuronal hyperexcitability. Seizures generally happen around the fifth day. And the semiology is usually focal tonic seizures, and seizures spontaneously resolve in early infancy, and they respond very well to sodium channel blockers, including phenytoin and carbamazepine, right? And they have a very normal neurological examination, normal neuroimaging, normal EEG, and they may or may not have a family history of neonatal seizure. So this is something which you should bear in mind. The severe ones are those which also can be due to KCNQ2 mutation. This is called KCNQ2 encephalopathy. So the benign variant is what is called BFNE or BINS. The severe one is called KCNQ2 encephalopathy. It presents with frequent seizures in the first week of life, and they do not have such a rosy prognosis. The EEG is bad in these children. The neurological examination is bad. The development is not going to proceed in a normal fashion in these children. And they generally have a very severe global neurodevelopmental disability. And again, the only thankful thing is that they respond to sodium channel blockers, including phenytoin. So these drugs can be used to suppress seizures in the vast majority of patients, but they may not be fully seizure-free. So when we discuss the very bad epilepsies, that is the neonatal onset epileptic encephalopathies, you should remember two entities: early myoclonic encephalopathy and the early infantile epileptic encephalopathy, right? So one is the first one I'll be discussing in this slide. It has a neonatal onset EME. As the name indicates, erratic focal myoclonic jerks are the hallmark of this condition. They can also have focal seizures. The typical EEG has a burst suppression pattern. Typically, they are caused by metabolic disorders such as non-ketotic hyperglycemia, biotinidase deficiency, pyridoxine dependency, that I've already told you about this, and propionic aciduria. Apart from that, you can have either of the previously mentioned causes leading to this particular pattern, right? So whenever you have such a pattern, myoclonus and burst suppression together, you should screen for metabolic conditions. The other condition is also called EIEE, as I mentioned already. This was previously known as Ohtahara syndrome. These seizures are usually different. They have frequent tonic spasms, and it is also associated with the burst suppression pattern. But the slight difference is that this burst suppression occurs during both awake and sleep, whereas in EME, it is generally in sleep only, right? So this also has very bad prognosis. In distinction with the first EME, which I discussed, Ohtahara syndrome is associated with structural brain abnormalities, including lissencephaly, other cerebral malformations, hemimegalencephaly, and occasionally icardic syndrome. When nothing of this is identified, you should screen them for monogenic mutations. One of the important ones include the ARX mutation, which can lead to this particular phenotype. So how do you classify neonatal seizures? So let's move into classification from the causes of neonatal seizures. In adults or in older children, we generally classify seizures as focal and generalized, but that is not possible in the neonate. Most seizures in neonate are focal in onset because of the poor myelination, right? So it is also very difficult to assess a child's awareness. Hence, we do not have this subclassification as aware versus impaired awareness. So the two basic heads under which we classify seizures in other age groups are not valid for neonates, right? It is important to note the predominant manifestation in a seizure. So if the child has myoclonus as a predominant manifestation, that has a direct bearing on the etiology. As I told you, when you have lots of erratic myoclonic seizures, you think of metabolic causes, as in the EME syndrome, which I just told you about. Whereas the first manifestation means that which part of the brain, gets activated first. So that leads to the origin or the focus of the seizure onset. So that leads to localization of the origin of these seizures. So that is also important to be noted. Frequently and thankfully, the first manifestation is also the predominant manifestation in a lot of neonates, but you may have a first manifestation which is different from a predominant manifestation. So it's important to note both. So in neonates, as against other older age groups, we talk of a concept called seizure burden. So seizure burden is defined as the ictal or a seizure activity in the EEG in a given period of EEG recording. So just as like we talk about person years or patient years, the seizure, the number of seizures multiplied by the duration of seizures gives rise to the seizure burden. So as I told you, more the seizure burden, more is going to be the neuronal damage, and greater is going to be the neurodevelopmental adversity in that particular neonate. So seizure frequency means the number of seizures. So a newborn can have 10 seizures in a day, which are very brief, lasting, less than 3 seconds or 4 seconds. And those children may not, those neonates may not have a bad outcome as that of, children who have just 5 seizures per day, but every seizure is 30 minutes in duration, right? So duration of seizure should be taken into account. So seizure burden is important. It has a direct correlation with the neurodevelopmental outcome. So there is an ILAE paper where experts have classified seizures and the epilepsies in the newborn period. So this is a position paper by the ILAE Task Force on Neonatal Seizures, just published in 2020. So according to them, when you have a critically ill infant with a suspicion of an abnormal movement, you always do a video EEG, and whatever has an EEG correlate only is characterized as a seizure, right? If you do not have an EEG pattern which correlates with a seizure, which does not correlate to the seizure, then you do not, consider it as a seizure at all, right? So accordingly, EEG can be either, seizures can be either electrographic only, or seizures can be electroclinical with a clinical sign, right? So EEG forms the basis of diagnosis of neonatal seizures, right? When you have a clinical manifestation along with a EEG pattern, so then they can be classified as electroclinical seizures. Then you subclassify them into motor and non-motor, right? So motor seizures include automatisms, clonic seizures, epileptic spasms, myoclonic seizures, and tonic seizures, whereas non-motor seizures include autonomic seizures and behavioral arrests, right? In addition to non-motor and motor seizures, newborns have a very peculiar group called sequential seizures, which I'll be explaining a little later. And obviously, in any seizure classification, when you're not able to group them into one particular group, then you put them into the unclassified group. So what do you mean by these seizure heads, right? So automatisms means they are coordinated motor activity, usually occurring when the cognition is impaired. This often resembles a voluntary movement and may consist of inappropriate continuation of whatever the child was doing before the onset of seizure. That is a pre-ictal motor activity. So typically in newborns, what you call, subtle seizures, or what you call, very vague phenomena come under this group. They're typically oral. They can be behavioral as well, right? So to differentiate this as seizure activity and not behavioral, we need an EEG. So automatisms cannot be very confidently diagnosed clinically, right? So this can be seen in HIE and preterm infants, that is term infants in HIE and preterm infants. And as I'll be telling later, there is a group called sequential seizures. Multiple seizure types occur in sequence, hence they are called sequential seizures, and automatisms are usually a part of these sequential seizures. Clonic seizures are very easy to recognize. Anyone would recognize a jerking, which can be symmetric or asymmetric, which is regularly repetitive and involves the same muscle groups, right? So it is a seizure type which is most reliably diagnosed clinically. And this is a typical seizure type, as I told you, in neonatal stroke or cerebral hemorrhage. They may also be seen in HIE, but when it occurs on only one limb repetitively, you should think of a seizure in the contralateral hemisphere. Epileptic spasms are sudden flexions or extensions or mixed activities of the proximal and truncal muscles that are usually more sustained than a myoclonic seizure. Myoclonus is very brief, a spasm is a little prolonged, but not so prolonged as a tonic seizure, right? So they can be mild forms of spasms, including grimacing, head nodding, or subtle eye movements as well. So these are brief in neonates, hence it is important to differentiate them from myoclonic seizures. But they are, as a group, they are rare in neonates. You will see more myoclonus in neonates than epileptic spasms, right? When you think of epileptic spasms and you diagnose them confidently, you should think of a genetic or a metabolic cause. Myoclonic seizures are very sudden, very brief, right? So they can be proximal, they can be distal, they can involve the axial musculature. They are the typical seizure type in inborn errors of metabolism. Just I told you, the seizure disorders including paradox-independent epilepsy, non-ketotic hyperglycemia, biotinidase deficiency, all these can lead to these kind of seizures. They may also be seen in genetic epileptic encephalopathy, right? So tonic seizures, again, are an important and a frequent cause of frequent type of seizures in the newborn. They can be focal, unilateral, or bilateral asymmetric. So you do not call a neonatal seizure as generalized tonic seizure, right? Generally, generalized tonic posturing as a seizure activity does not occur in the newborn because of the myelination, immaturity, as I told you. They can be bilaterally asymmetric, but they are not bilaterally symmetric. When they're bilaterally symmetric, you are going to call them generalized. So generalized tonic posturing, if they really occur in the newborn, they are not epileptic, right? So that is what you should remember. And there are a host of autonomic problems which can occur in the newborn, including cardiovascular, pallor, cyanosis, pupillary dilation or constriction, gastrointestinal issues, including vomiting, distension, pseudomotor, vasomotor, and thermoregulatory problems, that is, changes in temperature of the body. It can also involve the respiration, that is, it can lead to apnea. So it is rare in isolation, but it can be seen in extremely preterm infants as a result of intraventricular hemorrhage, as well as when there is a bleed into the temporal or occipital lobe, it can be seen. Right? Generally, they occur with other seizure types. So behavioral arrest means an arrest or a pause of activities, such as a vacant stare or a freeze or immobilization, as we describe it in lay terms. Again, this is also rare as an isolated type, but it can all be seen as a part of sequential seizure. So what is a sequential seizure? So this is a new term which has been introduced by the ILAE to describe a seizure, where a sequence of signs and symptoms, and sometimes the EEG changes also, keeps changing within the same seizure, right? So a child can start by having a myoclonic jerk, then they can go for stiffening, then they can go for behavioral arrest, then they can have pallor or cyanosis as an autonomic manifestation, right? So they all occur as in a sequence with changing lateralization. That is, they can be left clonic seizure, then they can be right clonic seizure, something like that, right? So this means that generally the child has a genetic epilepsy, such as which I had explained previously, KCNQ2 encephalopathy, or even the self-limited form of this KCNQ2 mutation, that is called BINS, or the familial form, right? So having said all this, apart from these clinical seizures, up to 50% of neonatal seizures can be only electrographic. And this is more so important in preterm infants, and particularly those with term infants with HIE, where the damage is primarily in the basal ganglia or thalamus, or those who are undergoing, cardiac surgery, or those children who are critically ill due to other causes. They may be given, sedative medications or paralysis, where you will not see the clinical manifestation. So an EEG only can be helpful in making a diagnosis of a neonatal seizure, right? So this is another classification in the paper. So you should know that automatisms, all these seizures, when you describe them, you should always use descriptors, trying to lateralize them. That is, whether they are unilateral or bilateral, right? Or they are focal, or they are really generalized. So you can see that there is no term called generalized here. Generally, it is now avoided. You avoided, that is, the term generalized is generally avoided in the newborn period, describing seizures in the newborn period. So automatisms can be unilateral, or it can be bilateral. It can be symmetric or asymmetric. Similarly, clonic seizures can be focal, multifocal, or bilateral. There cannot be a generalized clonic seizure in the newborn. Spasms are unilateral or bilateral. If bilateral, again, just like automatisms or like tonic seizures, they can be symmetric or asymmetric, right? Tonic seizures also follow the same subdivision of descriptors. Myoclonic seizures can be focal, multifocal. They can be bilaterally symmetric or asymmetric. So this is something we should remember when you describe seizures. Do not use the term generalized. So how do you diagnose neonatal seizures? So traditionally, neonatal seizures were diagnosed by clinical observation. You know that Volpe was the pioneer in describing neonatal seizures based on motor manifestations. He classified them as focal clonic, multifocal clonic, generalized clonic, tonic, myoclonic, and subtle seizures. The term subtle is still used by many neonatologists and pediatricians. It refers to seizures with signs such as abnormal eye movements, lip smacking, perioral movements, swimming or pedaling, cycling movements, or apnea. So modern EEG data have demonstrated that not all clinically suspicious events are epileptic seizures, particularly those with subtle manifestations and those like adult seizures, that is tonic, generalized tonic seizures. These two particular semiologies, when they happen, always you should be suspicious that they may be non-epileptic or non-electrical events. So motor automatisms and myoclonus were often, in addition to tonic, generalized tonic seizures, I would say. So these three kinds of seizures were often found to lack clear EEG correlate, right? So studies have demonstrated clearly that bedside clinical observation is very inaccurate for neonatal seizures. Hence, you always need to have an EEG to monitor for neonatal seizures. Only clonic seizures are reliably detected by physicians and nurses. This is the result of multiple observations and studies which have been published and has clearly established this fact. So as I already told you multiple times, most neonatal seizures are subclinical. The problem of electroclinical dissociation, as I told you, is very, very prevalent in neonates. The younger the neonate, the more is the risk for electroclinical dissociation, right? So isolated paroxysmal changes in the blood pressure or heart rate without any other clinical sign generally raises a clinician's concern, but it has been found out that it is not a primary manifestation of neonatal seizures. Hence, you do not need to be alarmed. So coming to EEG in the newborn period. So two important parameters are observed in an EEG. There should be two. It has been wrongly typed as one. So two important parameters are observed. One is a background activity and seizure activity, right? So whenever you read a newborn EEG, you should look for these two. So video EEG is always gold standard because it is critical to distinguish sources of artifact. Newborns can have newborns are generally kept in the NICU. They can have a lots of electronic interference from the ICU equipments, and they can have handling or patting related artifacts which can confuse the reader, EEG reader, if he does not have a video accompanying the EEG. Hence, the video EEG is important. And you have a lot of non-epileptic movements in the newborn which are benign, and they need to be differentiated from a seizure. So when you have a video, the information is invaluable. And along with a video, additional leads incorporating child's respiratory movements as well as electrocardiogram is important, because with that you can have a lot of information in telling whether this is really a seizure or not a seizure. So you define neonatal seizures on an EEG basis. As I told you, for defining any movement as a neonatal seizure, you need a EEG confirmation. So how do you define a neonatal seizure on an EEG? Right? So a seizure is an abnormal EEG pattern that evolves. That is, from time to time, it has to change. And it is of greater than 2 microvolts in amplitude and has a duration of 10 seconds or greater. It's a very arbitrary definition, but this is what is used, and this is what you should be remembered while reading a neonatal EEG. So the first line in the slide says that neonatal seizures may not have a clinical semiology. This should be remembered by everyone, every pediatrician who tries to understand neonatal seizures. It is very uncommon for individual neonatal seizures to be more than few minutes in duration. As I told you, that is a good news. But the seizures are often very frequent. So therefore, you don't have neonatal status epilepticus lasting for more than a few number of minutes. So you define neonatal status epilepticus again on an EEG basis, not a clinical basis, that seizures which occupy more than 50% of any 1 hour EEG epoch. So 1 hour EEG, during a 1 hour EEG, if you feel that more than 50% of the EEG has seizures, then it is a status epilepticus. So this is how you define neonatal status epilepticus. So this is just to show you a normal EEG background in a neonate. So what you can see here, don't worry about all these leads. Just see that the electrical activity is regular here. You can see continuous electrical activity, and all these very thick lines indicate muscle artifacts. So when the child frowns or raises the eyebrow or blinks his eyes or closes his eyes tightly, you can have these artifacts. So this is a continuous EEG, which is a normal pattern in a term newborn. Whereas in an abnormal newborn or a preterm newborn, you can have very fragmented activity. So this is called a burst suppression pattern, or a burst, as well as you can see long periods of very suppressed activity, which is called burst and interburst, right? So this is what a preterm EEG looks like, but in a term, if it is looking like this, then it is definitely abnormal. So this is what you see in the first component of EEG reading, that is background activity. So this is how a neonatal seizure looks like. So you can see a very regular pattern which evolves. You can see the frequency here is lesser than the frequency here. The frequency has increased, right? And it is associated with cessation of breathing. You can see these blue lines indicate, the respiratory pattern. Resp1, resp2 is the channel, right? You can see where the star mark is here. The breathing suddenly stops and the child becomes apneic for some time, and then slowly the rhythm increases, right? So this is an example of a neonatal seizure, right? This is just to show you how a neonatal seizure looks like on an EEG. So what are the indications for doing this test? So any paroxysmal clinical event which you suspect could be seizures, that is an indication. And you have encephalopathy due to any cause, that is hypoxic ischemic encephalopathy, or a stroke, or a CNS infection. You have some kind of an acute brain injury, and clinically the child is dull, child has encephalopathy, then that itself means an indication, because there could be seizures and you may not detect them. As I told you, most seizures are subclinical. So in this case, a routine length 60-minute neonatal EEG is generally inadequate. So generally we say that in older children, EEG done for a prolonged period of time is enough to screen for neonatal seizures, but neonates need at least 24 hours of conventional EEG if seizures are suspected, right? If seizures are identified, then definitely you should continue them until the seizure responds to medications and the child is seizure free electrographically for 24 hours. So 24 hours you don't have any seizures on the EEG, then you can probably discontinue the EEG monitoring. So when you use a routine EEG in the neonatal period, it is for assessing the background, as I showed you in the first 2 slides before this. So this is important because you want to see how the integrity of the brain as a marker of prognosis or an assessment of a gestational age. So when you have a child, a gestational age can be very easily estimated using the EEG based on several parameters, right? So most importantly, in the newborn intensive care unit, it is used to assess the state of the brain or the integrity of the brain as a marker of prognosis, right? And you should remember that therapeutic hypothermia alters the EEG patterns. So you should always interpret the EEG pattern in consultation with the neurologist, because a child who's not cooled and a child who's cooled show very different EEG patterns, and you may have a false sense of reassurance when you read the EEG in a child who has been cooled, but the child may not prove to be the same. So there is something called amplitude integrated EEG, which you should remember. An amplitude integrated EEG is a simplified trend monitor that displays 1 or 2 channels of time compressed processed EEG signal on a semi-logarithmic scale. So this is something which can be used and read easily by the NICU staff. Even those who are not physicians can make a diagnosis of neonatal seizures or see an abnormality in the background with this amplitude integrated EEG. So if a conventional EEG, it's very difficult to do a 24-hour conventional EEG in the newborn. So what this technology does is that it is a trend monitor, just like you see a trend of heart rates of the child during the day, trend of the blood pressures or the dips and rises and saturation you see as a trend monitor on the continuous fetal monitor. This displays just 1 or 2 channels of very time compressed and processed EEG signals, right? So that you can easily read them for highs and lows and then assess them for abnormalities, right? So they can be used to assess background patterns, especially neonates with hypoxic ischemic encephalopathy. But the use of this amplitude integrated EEG for seizure detection is controversial, but this tool is evolving in its utility. But it is not very sensitive in detecting seizures, but it is still being used in many of the neonatal intensive care units in the West, but primarily for the background pattern. So this is how an amplitude integrated EEG looks like. So what you see in panel A is a very normal pattern, right? So you can see that the EEG is continuous. There are just 2 EEG patterns which are seen here. So what you see in panel A are just 2 EEG channels, one on the left and one on the right. You can see continuous activity. This is the raw EEG. What you see below on the 2 strips below is the amplitude integrated EEG of the left and right, which shows a very thick pattern. You can see the amplitude is between 5 and 10, somewhere between 5 and 10. So the lower limit is 5 and the upper limit is slightly more than 10. This is a very normal pattern. This is called continuous normal voltage, right? So this is on B you can have, there is a EEG of an abnormal newborn with some encephalopathy. So you can see the EEG, raw EEG traces are not continuous. Somewhere you have flat line, somewhere you have continuous activity. So this is called discontinuous, but still it is in the normal range. So you have a very broad kind of a strip here, electrical activity strip, where the lower limit is lower and the upper limit is a little higher. So this is called discontinuous normal voltage. Again, this indicates mild abnormality in the background. Going to a much more severe severity of abnormality, in panel C, you can see that there are most of it, the EEG is suppressed, and there are small bursts here. So this is called burst and suppression. This is how burst and suppression looks like. You can see the lower margin is close to zero, and you can see some bursts which are coming. This is a compressed EEG, hence it is showing the waveform like this. So when you see such a waveform, you judge that the child has a very bad encephalopathy. And this is the worst form of encephalopathy in panel D, where there is a flat line bilaterally. So you can also see flat line here. So this is a flat trace, or the FT, which we call it. So you can see barely you can have activity. There are islands of high voltage activity. So this is a very severe encephalopathy in a child who has severe brain dysfunction. So how do you make an etiological diagnosis? So once you have confirmed that this is a neonatal seizure and you have classified the type of seizure, then the process doesn't stop there. You have to make a inquiry into the cause of seizure. So the diagnosis should occur in tandem with the diagnostic evaluation should occur in tandem with the treatment of seizures. So we'll go to the treatment in the last section. So when you check for the cause of seizures, you should always check for a blood glucose level and electrolytes, including calcium. And if they are abnormal, you have to correct it. And any neonate with seizure, always do a full sepsis evaluation, including cultures of the blood, urine, and CSF, based on the clinical status of the child. And empiric antibiotics are frequently started, at least on admission, until the cultures are negative or the sepsis screen is negative. So in most hospitals, it is straightforward to obtain a head ultrasound, despite it having a very low resolution. Cranial ultrasonography can be used to screen for obvious hydrocephalus or intracranial hemorrhage. Those are the two etiologies which can be easily diagnosed using an ultrasound. But if you want to check for other causes, if an ultrasound is negative, or you want to confirm the finding in ultrasound, an MRI is a standard neuroimaging modality. So you always do an MR angiography and venography, because you do not want to miss on vascular causes of seizures. If the cause after all these basic testing is not obvious, then you test for IEM, particularly when the seizures are refractory and you have an abnormal neurological examination, you screen for inborn errors of metabolism. If the child has congenital anomalies or dysmorphic features, or if a neonatal epilepsy syndrome is suspected, that is something like the 5th day fits, which we were talking about just now, you go for genetic testing. So this is what Swayman's textbook of pediatric neurology suggests. First line testing, you do all this, which I've mentioned already, right? And you always go back to the family and ask for history of neonatal seizures. If the cause is not evident, or you need to confirm a pathology which you suspect based on initial testing, go for a brain MRI. If you find your cause, then your diagnostic pathway stops there. If you suspect HIE and diagnose it on the E and on the MRI, then your job is done. If you suspect stroke, then you evaluate for the cause of stroke. That is, you do an echo. If the clinical suspicion of congenital cardiac malformation is there, you do a coagulation profile and an anticoagulation panel for venous thrombosis or thrombophilia workup, right? When you suspect an infection, you have signs of infection on the brain, then you go for torch titers and lumbar puncture and the PCR-based molecular study along with cultures. When you do not have either of this on the MRI, then you go for metabolic testing, and ultimately genetic testing may be required for confirming the diagnosis. Or in the case of these channelopathies, which I discussed previously, genetic testing is the only test which will give you a positive diagnosis. All other investigations will generally turn out to be normal. So how do you treat neonatal seizures? This is the last section of this lecture. So you treat neonatal seizures as early as possible. You have to treat them as aggressively as possible, because you know that the seizure burden has a direct bearing on the child's neurodevelopment later. So once you confirm them as seizures, then you start treating. But when you feel that they must be seizures even before electrographic confirmation, such as a child with high-risk conditions such as HIE, acute hemorrhage, or you very clearly have clonic motor hemiconvulsions indicating a stroke, you don't wait for an EEG confirmation, because treating seizures becomes more important. So you directly go ahead with treatment. Medication should be administered in bolus doses, as you know, to abolish seizures, including electrographic seizures. If you have a child with HIE, no clinical seizures, find EEG seizures, then give them a bolus of phenobarbital as a first antiepileptic drug. So it is the first and the most commonly used drug for first-line treatment of seizures. To date, data suggests that all medications have a similar efficacy. Not one medication has been proven to be more efficacious than phenobarbital. Hence, good old wisdom continues to exist. Phenobarbital has been recommended even in the latest guidelines for treatment of neonatal seizures, right? So maintenance should not be given for all children, all neonates. They should be initiated for neonates who have confirmed electrographic seizures. Or yes, in the second indication, which I told you for treatment, when you have high risk condition, definitely if you are going to discontinue after giving a bolus, then seizures are going to come back, right? So in children who do not have proven electrographic seizures, if you have given based on a clinical suspicion of seizures, you have given an anti-seizure medication, then you can discontinue and you may not give maintenance medication, but you will always have to do a proper EEG and review it frequently to ensure that the neonate does not develop electrographic seizures. So this is what Swiman's textbook suggests for treatment of neonatal seizures. You give a bolus of phenobarbital. If seizures stop, then continue electrographic monitoring until 24 hours of being seizure free. You continue with phenobarbital maintenance doses, right? If you do not have any any seizures after giving the phenobarbital dose, then you go for EEG monitoring, but simultaneously you give another bolus of phenobarbital, something like 10 to 20 mg per kg until seizure stops. So a cumulative dose of 40 to 60 mg or a targeted blood level of around 40 microgram per milliliter should be targeted. If they do not stop, then you go for second line agents. Again, second line agents are all equally efficacious. It may be fosphenytoin, it may be levetiracetam, it may be lidocaine. If they do not lidocaine or midazolam, if they do not respond to bolus medications. So the last two which I mentioned are infusions, right? So you choose them based on the other comorbidities the child has. So if the child does not have any cardiac or hepatic abnormalities and the cardiovascular status is stable, then you choose phenytoin or fosphenytoin. When the child has a cardiac abnormality or a hepatic abnormality or has hemodynamic instability, then go for levetiracetam. If the child has status epilepticus, provided the child has no cardiac abnormalities and has not received phenytoin, because a child who you're planning to initiate lidocaine, the child has already received phenytoin, it increases the threshold for a cardiac arrhythmia. So you generally, in such children, when these things are not there, then you go for lidocaine infusion. Lidocaine is very effective in the newborn period as an anti-seizure medication, right? So if you have no blood pressure and ventilation problems, then midazolam can be used and quickly hiked to the maximum dose which you prefer to use. So when you discontinue EEG, so acute symptomatic seizures typically arise within the first 24 to 48 hours of life. I already told you that after that, there is, after that short period of high seizure burden, generally seizures remit. So you need not think of giving a prolonged period of anti-seizure medications in the newborn. So overall, the duration of these seizures is usually something like 4 to 5 days, right? So because of the recurrence risk in the newborn period is low, many neonates can be safely discontinued from these medications. There is no need to wean medications that can be used, that has been used only for a short duration. Something less than 1 week, you do not wean, you can abruptly stop. EEG monitoring after the resolution of seizures. So once you feel that the acute symptomatic seizure period has gone away and the child is behaving well clinically, you need not do EEG again and again in the first 1 month, right? It barely adds anything to the prognostic, impression for that particular child. So the current tendency is to discontinue medications as early as possible and not beyond the first few days to first week. So the brief information on treatment of neonatal onset epilepsy syndrome. So if the diagnostic evaluation rules out an acute symptomatic cause, if HI is not the cause, if a bleed is not the cause, if an infection is not the cause, then you should think of early onset epilepsy. The treatment of epilepsy in neonatal period is different from that which we use for acute symptomatic seizures. So this is one condition where you should not be very aggressive in treatment of seizures, right? So because you're not worried about the seizure burden right now. And another important reason is that, a diversion from the way we treat acute symptomatic seizures in newborns is that they must continue discharge medications when you send them home. You did not aim to stop or discontinue, as I told in the previous slide. What I told in the previous slide holds good for acute symptomatic seizures, not for those with epilepsy syndromes which have an onset in the newborn period, right? So you need not be very aggressive initially. You can slowly titrate them, because you should think of tolerability in the long-term period, right? Because missing 1 or 2 seizures, brief seizures during the neonatal period is not going to affect them much. But if you give a very high dose and the child is going to be sedated, it may affect the child's quality of life, right? You should always think of giving IV pyridoxine whenever you have refractory seizures. Preferably it is done while the EEG is ongoing and you give an IV preparation. The infant should be monitored, because apnea and bradycardia can be complications of IV pyridoxine. If you cannot give IV pyridoxine, give oral pyridoxine. A dose of up to 30 milligrams per kg can be started in 2 or 3 divided doses, and it may take days to weeks for the child to show a response on oral medicine. If you are confident that there is no response to pyridoxine, then you give a trial of pyridoxal 5-phosphate. The dose is up to 60 mg per kg per day, divided 3 times a day for 2 to 3 days, and then folinic acid can also be attempted. This is also available outside India as a IV preparation. Here only we have all these drugs in oral preparations. And you should know that KCNQ2 or KCNQ3 mutations, as I had explained in detail in the previous slides, these are very highly responsive to sodium channel blockers, including phenytoin and carbamazepine. So I would conclude with a series of recommendations from the very recently published special report from the ILA Task Force on Neonatal Seizures. This is a consensus-based recommendation, right? So this is regarding just the treatment of seizures in the neonatal. So the first recommendation is that in neonates with seizures requiring a medication, phenobarbital is a first-line anti-seizure medication. It should be the first-line anti-seizure medication regardless of the etiology. And if a channelopathy is very highly likely, then you think of starting a sodium channel blocker like phenytoin. So only when you're sure that this is probably due to KCNQ2 or KCNQ3 mutation, then you think of starting this. The second recommendation is that the second-line medication, there is a host of medications including phenytoin, levetiracetam, midazolam, or lidocaine. Either of this can be used as second line. There is no difference between each of them. If you suspect a channelopathy because of clinical or EEG features, then obviously you should use sodium channel blockers. If you had used something else initially, phenobarbital initially, then you should switch to a sodium channel blocker like phenytoin or carbamazepine, depending on the clinical state. So if you have a well baby, then probably you can give oral carbamazepine, but you know carbamazepine is not available as IV preparation. So if a sick child is there, you will be obliged to use phenytoin, right? So if you have a cardiac disorder, levetiracetam is a preferred choice, because in that particular scenario, you won't be able to use phenytoin or you won't be able to use lidocaine, hence you go for levetiracetam. The third recommendation is regarding the duration. So you know now that following cessation of these seizures, both EEG and clinical seizures, without if you're confident that there is no evidence of neonatal onset epilepsy, that is, there is no genetic or metabolic cause, your intention should be to withdraw anti-seizure medications as early as possible, even before discharged home, regardless of MRI or EEG findings. You don't, because the EEG shows abnormality or MRI shows abnormality, even in a child with hypoxic ischemic encephalopathy, if the child has crossed that particular acute symptomatic period, then you try to stop anti-seizure medications and send the child home without any medications on discharge, right? So the fourth recommendation is on the impact of therapeutic hypothermia on seizure burden. So therapeutic hypothermia may reduce seizure burden in neonates with HIE, but the impact of this particular treatment modality as a treatment modality for seizures has not been assessed. So there are studies to show which have proven that therapeutic hypothermia may be useful in improving the neurodevelopmental outcomes of children with HIE, but there are not enough studies to say that therapeutic hypothermia is an anti-seizure therapy which is recommended to use, right? So though it may reduce seizure burden, it is an added advantage, but this is not a proven modality of therapy for neonatal seizures. The fifth recommendation is on the association between electrographic seizure burden and outcome. So this we already know. That is why we have to treat neonatal seizures, including the only EEG seizures or electrographic seizures, to achieve a lower seizure burden, because it is directly translated with improved neurodevelopmental outcome and decreased risk of subsequent epilepsy in the infant. The sixth recommendation is regarding pyridoxine. A trial of pyridoxine should be attempted in neonates presenting with clinical features or EEG characteristics. What are the EEG characteristics? As I told you, something like burst suppression seen on the EEG, or a myoclonic seizure which has been visualized in the video EEG. Something like that, you should start vitamin B6 or pyridoxine. If a neonate has seizures which are unresponsive to second-line medication, but you do not have an identified etiology, if you do not have HI, you do not have an intracerebral hemorrhage or a stroke, but you still have seizures, then you can close your eyes and start pyridoxine followed by pyridoxal 5-phosphate. The last recommendations are those for quality improvement. It says that there is a need for standardized treatment pathway for the management of neonatal seizures in every neonatal unit. It may differ from one neonatal unit to the other. It may not be right, it may be wrong, it may be right, but it has to be the same for each neonatal unit. That is called protocolized treatment pathway. So this should be implemented in every neonatal care unit for good and optimal outcomes. And it is always important to communicate with the family. They should be informed that an acutely ill neonate needs these medications for this particular cause of seizures, and the nature of these seizures, and what are the other treatment options available, and obviously the potential adverse effects of anti-seizure medication, and the expected trajectory and the probable duration of treatment. This all should be not just discussed with the family, also to be documented in the notes. So the outcomes of neonatal seizures is always of interest to the clinician as well as the family. So they are associated with an array of adverse outcomes, including very good outcome or no adverse effects. On the contrary, on the other side of the spectrum, you can have intellectual disability, cerebral palsy, post-neonatal epilepsy, and death. It depends on three important factors. One is etiology of the seizures. Second, the seizure burden, which I have told repeatedly. And the third one on comorbidities, whether the child has, neonatal sepsis, prematurity, and hypoglycemia as a comorbidity for the primary etiology of hypoxic ischemic encephalopathy. All these are interdependent. So post-neonatal epilepsy is one in which the acute symptomatic seizures in the newborn period subside, but later on, after a few months to years, the child develops recurrent unprovoked seizures. It affects up to 25% of survivors of neonatal seizures. Again, there are clinical and EEG risk factors. When you have the requirement of more than one medication to control the acute seizures, or you have moderate or severe neonatal encephalopathy or abnormal neuroimaging and low birth weight, then probably the child has a higher risk of post-neonatal epilepsy. EEG-based risk factors include the presence of status epilepticus. As I told you, more than 50% of a 1-hour EEG epoch, if it has electrographic seizures, then it is called status. So this is a risk factor. Persistently abnormal background. That is why in EEG, background is very important. Multifocal versus focal seizures. So more the seizure, more hemispheres it affects, greater is the chance of post-neonatal epilepsy, and ictal spread to contralateral hemisphere. So all these are logically possible, and these are risk factors for post-neonatal epilepsy. So as a summary, clinical observation is unreliable for neonatal seizure detection. Hence, EEG is the gold standard for neonatal seizure diagnosis. So you can have electrographic only seizures, but you cannot have clinical only seizures. You can have electroclinical seizures. So when a seizure is confirmed with an EEG, only then it becomes a valid or a true seizure. Newborns typically have a high seizure burden. It is rare to have only 1 or 2 seizures, but they are generally very brief, right? And most neonatal seizures, up to 85%, have an acute symptomatic cause, including HIE, vascular causes, and infections, which top the list. If seizures persist beyond 96 hours, they're probably not caused by an acute symptomatic cause. It is probably epilepsy syndrome due to a genetic or metabolic cause, right? Electroclinical seizures can become subclinical seizures after treatment is initiated. So this is called electroclinical dissociation. This happens in 2 conditions. One, when you treat them with a drug affecting the GABA pathway, which is one of the examples, and the most common drug is phenobarbital. That is why after the clinical seizures subside, you should always look for electrical seizures which are ongoing, right? And therapeutic hypothermia as well, as I told you, is an important cause for electroclinical dissociation. Hence, EEG should be aggressively used to monitor for seizures and treat them when they are found. So phenobarbital remains the first line treatment. Consider pyridoxine and phenytoin in appropriate clinical settings. Pyridoxine when the seizures are refractory and you have clinical evidence of pyridoxine-dependent epilepsy, and phenytoin when we suspect KCNQ related channelopathy. The duration of treatment depends on etiology. For most acute symptomatic seizures, anti-seizure medications can be discontinued to discharge. You do not give them for a longer period as had been given previously, and don't use any investigation like an MRI or EEG for deciding on the need for continuation of anti-seizure medications. And the most important prognostic factors for neonatal seizures are the etiology, the primary cause, and the severity of the primary cause, and the seizure burden. So one cannot meddle or modify the cause. The only modifiable risk factor or prognostic factor for long-term prognosis is the seizure burden, and that is where one should act and try to intervene. Thank you.